Wellbeing Overview Scrutiny Committee. I'm Victoria Holloway. I'm the chair of the committee. As it's our first meeting of the municipal year, I thought we'd all introduce ourselves, councillors and officers alike. So if I start to my right and we can work our way around, just introductions, please.
Good evening, Councillor Grahamsdale.
Good evening.
Councillor Tony Fish.
Councillor Gary Collins.
Good evening, Councillor Aaron Watkins.
Good evening, Tim Elwell-Sutton. I'm a consultant in public health representing the Director of Public Health.
Good evening, Fumi Worrell, Public Health Registrar.
Good evening, I'm Catherine Wilson. I'm the Strategic Lead for Commissioning for Adult Services.
Hi, I'm Roger Harris. I'm the Corporate Director for Adults, Health and Housing.
Hello, I'm Mandy Ansell. I'm the Accountable Officer for the Clinical Commissioning Group.
Hi, I'm Jess.
Hi there, I'm Ian Evans, Director of Thurrock Coalition.
Good evening, I'm Christina Jackson, Chief Exec at Thurrock CVS on behalf of Kim James of Health Watch.
I'm Councillor Holden, I'm the Cabinet Member for Health.
And my name's Jenny Shedd, I'm Democratic Officer, Clerk to the HOSC.
Thanks everyone. I look forward to working with you all this year. I want to remind everyone present that this meeting will be recorded for publication on the Council's website and will be normally available within 3 working days of the meeting. I also want to remind members and officers to use their microphones when speaking, but you've already achieved that, so we're golden there. And lastly, I just want to emphasise that we've got a very busy agenda this evening, so I want to keep those who are presenting to time and questions from councillors as succinct as possible, please. First item, apologies for absence. I've received an apology from Kim James, Health Watch Co-operative Member, and Ian Wake, Director of Public Health. Are there any further apologies for absence?
No, Chair. Thank you.
Okay. The minutes. I move that the minutes of the Health and Wellbeing Overview and Scrutiny Committee held on the 16th of February 2016 be approved as a correct record. Are there any comments on the accuracy of the minutes? Can we all agree them then?
Agreed.
Brilliant. Any urgent items of business? I've not agreed to any items of urgent business this evening. Declarations of interest. Does anyone wish to declare a declaration of interest? Okay. So the first item on the agenda... Oh, no. Apologies. Items raised by Health Watch. Christina, in Kim's absence, are there any updates that you'd like to provide the committee on any Health Watch?
Kim will bring a report to the next committee, but just to update members that Health Watch are currently conducting a survey on the health and wellbeing strategy refresh on Goal 1, and that will inform the action plan going forward.
I think we look forward to hearing that from Kim next time. Item number 5. Report on Specialised Commissioning East of England Overview. The report can be found on pages 13 to 34. I'd like to introduce Jess Kinghorn, Head of Communications and Engagement, NHS England Specialised Services, and Ruth Ashmore, Assistant Director of Specialised Commissioning, NHS England, Midlands and East, who are here to introduce the report and the presentation. I'll hand over to you both.
Sorry, I hope you've all had an opportunity to read it, and perhaps we'll zip through it and then give an opportunity for questions relevant to particular issues for you. So first and foremost, to introduce ourselves, as I said, I'm Ruth Ashmore. I'm the Assistant Director, a clinician by background, and have been in the health service about 35 years, so I should get a long service medal soon. And my colleague, Jessamy Kinghorn.
Yeah, I've been working for NHS England for just the last year. Prior to that, I worked for an acute trust and mental health trust for 15 years. So my experience is also very much NHS, but on the provider side of things. So I'm used to working in a hospital.
thought it was useful to give you an overview of what specialised commissioning services are, particularly as some of you may be new to what specialised services are. And so, first and foremost, this is just an overview. So, specialised services are directly commissioned by NHS England and are those services that are usually planned on populations greater than 1 million. That means that they are usually small in volume or high cost. But there are some services that fall within the remit of that are provided at every hospital in the east of England, and some of those we'll talk about. So in terms of what they are, they're usually complex, high cost and rare, and they are usually at the cutting edge of services in terms of new services. So you might have heard very recently about cancer drug funds, and where some of the pressures are for NHS England in terms of cost pressures are absolutely within the basket of funding for specialised. There are over 140 commissioned services that NHS England look after, and they are commissioned by 10 hubs across England. And all specialised services are commissioned to a consistent national model and standard. And policy for those services, those 140 services, is set nationally with national specifications. There is a robust clinical oversight and advice to those through 42 clinical reference groups, which are organised in 6 national programmes of care: internal medicine, cancer, mental health, trauma, women's and children's, and blood and infection. This is just a little bit more overview in terms of the expenditure and cost. So the total budget across the portfolio for NHS England Direct Commission is 15 billion, and it's rising exponentially each year. So it is at the extreme end of the cost pressure, as I said. For the east of England, our budget is just over 1.1 billion pounds worth of activity that we commission across the 19 acute trusts across the east of England, mental health providers, independent sector mental health providers as well. That's just to tell you what factors determine whether services are specialised or not. And as we've said, that's just a reiteration of what we've already said. So specialised services are fundamental to the values of NHS England, supporting people with that rare and more complex condition, often in times when they're greatest need. And there were a number of reforms that took place in 2012 as part of the reforms. Since that discussion, it means that we are, and NHS England in its direct commissioning role, have responsibility for those services. What we do know is, like most services across the NHS, there is variation. So although we commission nationally and we have national specifications, there is variation. And some of the fragmentation in terms of commissioning that has occurred since 2012 also means that the pathway of care is often split, and patients sometimes are not aware of that, or sometimes get caught in the complexities of that fragmentation of commissioning. But in terms of the challenges so far, we, like the CCGs, are very much working towards the vision in terms of the 5-year forward view, in terms of improving population health, ensuring that we have high quality care systems, and maximising the efficiency or the money that we spend in terms of UK PLC. And we recognise that we are proportionally taking more of that spend each year. So we do really need to work as commissioners across, like CCGs, in terms of prevention and ensuring we do as much downstream so that we can stop the spend upstream. In terms of the challenges for specialised commissioning, so at NHS England-wide, they're exactly the same across the health profile that you in Thurrock have in terms of inequalities in health, an ageing population, a growing population with chronic conditions, the financial challenge, and workforce pressures. And that's particularly pertinent for specialised services, where these very rare specialist people, nurses, doctors, allied health professionals, are becoming an issue in terms of sustaining specialised services everywhere across the country and locally. And some specialised services are spread thinly, and perhaps too thinly. in terms of the challenges for specialised, it's the demand and that growth and the demand in cost, which for every penny we spend in specialised commissioning means that at CCG and Health and Wellbeing Board level, it means less money for you to spend on your patients on that really important prevention work and that agenda. New technologies are at a cutting edge for us, and we have over 80 policies, including drugs and devices, that potentially could come on stream and be another significant cost pressure. And with all services, we often don't have substitution, we have growth in those areas. There's the impact of the policy changes in terms of how much money's in the system. There's a lot of political oversight in some of the services that we look after on your behalf, cancer, CVD, those kind of things. And there are new models in terms of commissioning, how we might commission services jointly for the future. And then there's also how do we maintain local clinical engagement at every place. And there is a requirement, just as there is at CCG level, for much more integration and single systems and working smarter. So there's a national strategy that needs to be developed and is in development by NHS England with its stakeholders, which is contributing to the 5-year forward view. And at its simplest, there is a look at whether there needs to be fewer larger providers for some of the specialist elements of care because of all the pressures we've just talked about, whether that it can be done in a hub and spoke fashion in terms of making sure care needs to be delivered locally where possible, but actually working collaboratively across a number of organisations. So mirroring some of the success work that's going on in Essex. New commissioning models, how do we do co-commissioning, how do we work in a lead provider framework, and how do we ensure that we're getting best value for money. There's an increased emphasis on performance and quality monitoring as well. And then the biggest thing for us, and probably one of the things that keeps me awake at night, is how we manage new market entrants in terms of drugs and interventions. And some of you may have listened to the debates that have been going on around the Cancer Drug Fund, which is quite a large issue for us. So this is just to tell you the top 10 services that we commission. Now the spend here is national spend, and you can see the growth. So there's chemotherapy, and most of what we commission, all chemotherapy drugs and delivery across all of the hospitals. The high-cost drugs, we commission those, and as you can see, that's large. And then the rarer cancer pathways at the top end of that. Cardiac surgery, so we are the main commissioner at Basildon for the Essex Cardiac Centre, and we are the main commissioner at Addenbrooke's and Papworth. Neurology is a large component of what we commission. Neonatal intensive care, we are the commissioner. Paediatric intensive care, renal dialysis and transplantation, liver services and pancreatic, and then neurosurgery. So it just gives you a flavour of our portfolio and those top 10 services and the spend. What's driving the growth? This is just a bridge in terms of, as I said to you, our 6 services nationally and locally. What do they mean, and what's the issue? So our top spend is chemotherapy, secure mental health, renal dialysis, neurology, neonatal intensive care and neurosurgery, and those are growing. We have major issues in terms of secure mental health and transforming care and working with learning disabilities as well. So some key facts about Midlands and East. We can skip over those. Our budget, our share is 3.7 of that 15. The population is 17 million. Across the Midlands and East, there are 61 CCGs, 72 trusts, and we, on behalf of the CCGs and stakeholders, manage 81 contracts. And we have 16 aligned STPs to 3 commissioning hubs, and we have worked with 6 STPs across the east of England. In terms of top contract value, this gives you a flavour, but our biggest contract value is Addenbrooke's at 250 million. So we are half of the contract value of Addenbrooke's, and we look after that on behalf of the east of England. So that just gives you a flavour. In terms of what is the work programme, this just gives you a flavour of the national work programmes of care. So how do we look at service redesign? How do we look at ensuring that we have the right commissioning policies? How do we ensure that patients are engaged, clinicians engaged at a national level? And that just gives you a flavour across the 6 programmes of care where the key areas of work are. And just to give you a little bit of flavour about the emerging priorities, there are some national ones which are to the fore of our minds, and that is about child and adolescent mental health services, particularly Tier 4. We commission those on your behalf and work collaboratively with our CCG colleagues and local authority. Medium and low secure, gender and gender reassignment, we manage that, and there is an increasing waiting list. Perinatal medicine, and we have some growth, so some good news. We have some investment that's going into extra perinatal beds. And then our biggest piece of work is supporting the transforming care agenda. So ensuring patients with LD are managed more appropriately in community settings as close to home as possible. And we have about 107 patients across the east of England. And we're working through what that means and how we work with local authorities to ensure that where money needs to flow and support patients to live in the community, that happens. But where they also need highly specialised mental health provision, that we have an opportunity to ensure the money moves with the patient. In terms of cancer, we have a look at radiotherapy and particularly some highly specialised radiotherapy. We have a look at internal intestinal failure, that's highly specialised, and there is a major review at national level of congenital heart disease patient pathways, and this is particularly around looking at where children's congenital heart services will lie and then the pathway for those patients. Spinal services, paediatric burns, because we have one of the national centres on our doorstep at Mid-Essex for paediatric for burns, both adults and children, and paediatric epilepsy. But if you look particularly for us in the east of England, where our particular focus is CAMS Tier 4 and the procurement of that, looking and making sure we have enough of the right beds in the right place to deliver and support Tiers 2 and 3 and the transformation work going on there, the perinatal Tier 4 work and transforming care. And then for blood and infection, we've had major investment in supporting hepatitis C nationally, and that is about long-term support to patients with hepatitis C. HIV procurement, we procure and support the HIV element of sexual health, and we are doing that on your behalf. Then for cancer, we've got a number of reviews going on, but the ones pertinent to you are obviously the Essex Urology, and that clinical visit takes place next week, and the recommendations will go to NHS England in the next couple of months. There is the PET-CT review that's going on in where the best site is for that, for the long-term feature for the South Essex population. And then in terms of internal medicine, we've got a vascular stocktake, which will report to the Essex Success regime and make some recommendations as to where that would be best sited for your population moving forward. We've got some major pressures on neurorehabilitation and spinal services that we are looking at with London, and then we also need to have oversight of what will happen in terms of neonatal critical care, and looking at if there's a need to have a look at that. But we've done our reorganisation some years ago in the east of England. So in terms of the next couple of slides, they just give you a little bit more detail of those areas of work, and I suppose you might want to ask some questions about those rather than me go through, and I hope I've given you a flavour of those particular areas of work. We have tried to give you what this involves, and then the size of the service and the numbers of patients potentially this might be effective, and then the timescales for the work programme, and coming to you in the fullness of time to have those discussions. So that just gives you that kind of approach. We are testing out with you how we as specialised commissioning communicate and engage with you as a HOSC here in terms of that and what that looks like. So we have 3 HOSCs in Essex, yourselves, Southend and Essex, and it might be worth us beginning to look at how we work collaboratively together, bearing in mind that most of the decisions are based around bigger populations of that million population size, but recognising you absolutely need to be assured and reassured that your patients are getting equal access and have an opportunity to be engaged in those discussions and decision making. So that's just for your information, and just to give you a little bit more flavour, I wanted to give you more time to talk to us. So I have a boss. Everyone has a boss. My boss is Catherine O'Connell, and she knows Essex quite well. She used to be a CCG chief executive in Essex. We're based as a team in Fulbourn, but we cover the whole of the east of England. So we find ourselves in our cars quite a bit, and as I said, we cover all of those services. But that's kind of the top team. So I wondered whether it would be an opportunity to ask questions. I hope that was useful and gave you a little bit of a insight into what we do and who we are.
Great, thank you very much, Ruth. It was a very comprehensive and detailed report, so I appreciate you putting that together for us. Does anyone have any queries or questions for Ruth and Jess? Councillor Collins.
Sorry, can you hear me now? Okay, I see you especially you're commissioning more services for paediatric burns. Is there a rise in paediatric burns? What's the cause?
No, it's essentially Mid-Essex is our major provider for paediatrics, for paediatric and adult burns, and there's just been an issue about whether the numbers are actually tiny. You'll be pleased to know, very tiny, and it's just about having the most suitable services that wrap around children who require specialised burns care. So we have an arrangement currently with both Great Ormond Street and Birmingham for children who require specialist help and who cannot be managed at Mid-Essex.
Right, thank you. May I ask another question? It's in the report in the pay or slide 1 of 3. It was Essex HIV service. It just says the number of patients or size of service, small numbers. Do you have any number on those? Please.
I don't have them in my head, but we commission on your behalf the HIV services with a number of clients at the moment. The local authority commission the sexual health pathway, and because there are small services, it's looking at whether we can get the best value and that supports patients in the right way. So I could find you the numbers. I can certainly give you that. I don't have them on the top of my head.
Okay, just an idea. I just want an idea if the numbers were increasing.
I suppose what you ought to be aware of, probably the biggest expense is the drugs. The drugs are the major element, and there is also a discussion about whether there is a prevent agenda in terms of supporting the community to look after themselves, and effectively that might have a cost pressure for both NHS England and local authority moving forward as well.
Okay, thank you. And can I ask one more?
Yeah.
This is to do with... This is slide 3 of 3, gender reassignments.
Yes.
That comes as a surprise to me that we did that on the NHS.
So yes, this is one area of work that is increasing, and the increase is across both adult and children. So we have a rising demand curve, and we have not quite enough providers. So this last financial year and this year, NHS England have commissioned more services. And so, but we do have quite large waiting lists for this service.
You gender reassign children?
What we offer to children is a service provided by the Tavistock Centre in North London that provides care and support to those children who are recognised as requiring help. We don't physically do surgery until they reach 18, if that's their wish.
Right. How long have we been doing this, really?
A long time, forever. So I suppose what you might be saying is, when we are thinking about other services, but this is a nationally commissioned service that is essentially commissioned on behalf of the whole of the country at a number of centres. We don't have a centre in the east of England, but we do have a number of patients, obviously.
Brilliant. Sorry,
what sort of... do you mind?
No, I can get up one more intervention and then I've got to bring other councillors in because you've had three questions.
It's just that I was doing some research and they tend to be like the Swedish survey on gender reassignments, which come out in 2004, I believe, which had highlighted negative outcomes for a number of cases of surgery, higher incidences of suicide, attempted suicide. Have we followed up on our patients in this country?
So yes, there is an outcomes measure that's included in the specification, in that national specification, and yes, there is quite a high instance of suicide in patients who are not put on a pathway. So I think, like anything else, it's subject to looking at both of those questions in terms of, do patients not do well, and do they have psychological and mental health issues as a consequence of not being offered gender reassignment and support, so there is a very, very clear access policy, and there is a very clear psychological assessment done of all patients before they are offered it.
Thank you, Ruth.
Thank you.
No problem at all. Councillor Snell.
Thank you, Chair. An observation first, and then a question afterwards, regarding the drugs thing. For my day job, I'm in shipping and freight forwarding.
Yeah.
Now, I won't mention the names because that wouldn't be fair on those, but I work with a few companies that source drugs and appliances in the EU and send them to Africa. Well, they don't really, but that's what they say they can do. And it is massively cheaper, and they're buying them from the big pharmaceutical companies and the big providers. Do you get the feeling that we're probably being charged too much for stuff in the UK? Because these companies are sending them out, not really, pretending they are, and then just sending them back into the UK at a much reduced rate.
So NHS England has a large medicines optimisation group. We have embedded pharmacists that work with CCG pharmacists and our own providers and the procurement hub across the east of England. And there is national procurement of drugs where it makes sense to do so. There are certainly conversations with pharma on a weekly, daily basis, and NICE, who will also need to look at the economic affordability of some of these drugs, and we are absolutely looking at where we can optimise value for money.
My question. My question. Thank you for that. Just a word on the PET CT scan. I mean, obviously it's quite sort of dear to our hearts.
Yes.
Have you got an update where we are with that at the moment?
Yeah, so we have finished the engagement exercise, and it's fair to say we've had extremely good engagement from both your community, the Basildon and Brentwood community, Southend and Mid-Essex. We've had a number of roadshows that run into quite significant numbers. We've had 40 patient surveys returned. We've had 19 clinician surveys. We've had 4 community group meetings over 3 months plus, and we expect the decision to be made in July.
Thank you for that update. I noticed that in the minutes of the last meeting, so you picked me to it there. Councillor Watkins.
Thank you, Chair. In regards to the perinatal centre opening up for Anglia, covering obviously multiple areas. Obviously, it mentions there will be extra beds available for Essex, Bedfordshire, and Hertfordshire. Do you happen to know how many extra beds there will be for Essex and how they get divvied up between the 3 areas?
Okay, so this is new money that's come into the system to absolutely support perinatal mental health, because there was a concern that there wasn't enough Tier 4 beds. We were very lucky in the east of England in that we have a provider in Hemel Hempstead with Hertfordshire Partnership Trust, and they have 8 beds, and it's a fabulous new service. They are currently looking at whether they can increase their numbers, but it might be that we look to have an outreach model to absolutely support women and families as close to home as possible. The other services in North East Essex by North Essex Foundation Trust, and they are constrained currently by their footprint, so they cannot increase their inpatient capacity, but again they are potentially looking at an outreach model that would support the Anglia conversation. So there was, when you looked at the geography, there was quite a large gap between Norfolk, Suffolk and Cambridge, and so we are going through the exercise to look at and see where that was best placed, and we will do that through either a formal expression of interest or procurement. So that is ongoing at the moment. So it's absolutely a little bit of good news, but it will be constrained just in terms of how that comes on board.
Brilliant, thank you. And one last question from Councillor Fish.
Thank you, Chair. I'm interested in the item on transforming care. In my experience with people with autism, if you work with them from a very young age, you can give them a lot of support and actually help them a lot as they're getting older. The more holistic approach that you take, the better the outcome. So although it talks about a system-wide approach, are you looking at commissioning services jointly with other agencies such as education?
That is the territory. So we only look after the top end of the pathway. So we are responsible for those patients who are in high, medium and low secure services. And there is absolutely an intention, and children in Tier 4, children with learning disabilities in Tier 4 CAMS, we are absolutely engaged with trying to move patients where they no longer require security and protection and support in that secure setting back into a community setting. We work in terms of transition, but there is an unmet need for children with ASD and learning and severe learning disabilities, and that is a bit of a national issue at the moment. I mean, I've certainly done a number of care and treatment reviews very recently for children across the east of England, because that's my clinical background, and the unhappy nature is that there is a real gap for support to children with learning disabilities and ASD, in that services tend to finish at 12, and they certainly do in this part of Essex, and then there is nothing until potentially they end up having had their education and then falling off a bit of a cliff. So there is absolutely a need to work together, and that's what we're doing at the current time.
Brilliant. Thank you so much for your presentation again. So in that case, can I ask members if we agree the recommendations in the report, to note the report?
Agreed.
Brilliant, thank you. Jess, Ruth, if you want to leave, you don't have to stay for the rest of the meeting.
Jess is going to go, but I'm going to stay to listen to
No problem
Wendy's.
at all. You're very welcome.
Thank you. Thank you very much.
Okay. Moving now on to item number 6, which is the report on the public health grant found on pages 35 to 42. Tim, can I ask you to introduce the report, please? Thanks.
Sure, thank you, Chair. So this report is really an update on where we are with the public health grant. So every year the local authority is given a grant from the Department of Health to be used exclusively for public health services. It's a ring-fence grant. We've had very significant cuts to the grant since last year. We had an in-year cut last year, followed by further cuts this year and further cuts anticipated next year. amounting in total to about £1.2 million we'll have less next year than from our baseline, which is close to 10% of the total value of the grant. Steps we've taken so far to deal with that financial pressure includes renegotiating our contracts. So most of our spend is tied up in contracts with NHS providers, and most of those run until March next year. What we have been able to do very effectively is negotiate quite hard with our current providers to reduce costs within the current contracts. And actually our current providers, particularly NELF, who provide the bulk of our services, have been very accommodating in that. In most cases we have been able to reduce the cost of those contracts without having an impact on frontline services. There have been some smaller services decommissioned, but in the main we've been really successful in managing to reduce cost without cutting services to the population. We've also managed to make some savings in terms of staffing, carrying some vacancies within the team. With all that, we are anticipating that we will be within our financial envelope this year, but next year, unless we find extra savings elsewhere, we're looking at a structural deficit of around £340,000. So the plans to deal with that are threefold, really. We've probably done as much as we can in terms of salami slicing the current services. So what we're planning to do is redesign and reprocure most of the services we provide. And we think there are efficiencies to be made through cutting out overlap and really designing more integrated services. We're working closely with the CCG on this. So a good example, the biggest area of spend we have actually is our 0 to 19 services. So that includes things like health visitors, school nurses, and a range of school-based programs. We're working very closely with the CCG and other parts of the council to rationalise services, because there is some overlap in the current commissioning environment. So we think there's scope to make savings there. Again, we hope in the main we will be able to reduce costs without reducing the amount of the services that are being provided at the front line. In fact, in some cases, I think we can actually improve the service by doing things in a more integrated way, because often that's better for patients or the population as well. On top of that, we hope we may be able to generate some income, so we feel we have some unique skills within the public health team, particularly in health informatics and data analysis. So we're looking at ways of generating our own income. At the same time, there's a job to be done in terms of improving the reach of what public health does, both across the council and to the CCG. So I think it's fair to say previously the core offer, as it's called, the public health support that comes to the CCG was not strong in the past. That's been much strengthened, and we're hoping to strengthen that more in future. But at the same time, we're hoping to work more across the local authority as well. So we're working more closely with colleagues in environment and health and adult social care, because we think we have skills to provide there, and actually public health requires that kind of cross-cutting approach. It's not just about what we commission, it's about some of the broader determinants of health. So really this report is an update on where we are. We'd like the committee to approve the plans we have for reprocuring, redesigning our current services, but also reshaping the public health offer across the council and the public sector more generally. I think I'll stop there.
Brilliant. Thanks very much, Tim. Has any members got any queries or questions for Tim or comments? Councillor Snell.
Thank you, Chair. This kind of crosses over to the next one a little bit, but it's mostly to do with this particular item. I know obviously we've got a table 4 here, which is the services that you sort of negotiated down that we're currently. But I was looking at the tobacco control one, where we're going down from 467,000 to 392,000, which And yet, in the next item, we've got that 0.3% of the smokers successfully quit long-term as a result of the Commission's Stop Smoking service. My question is that money well spent, or is that something that can be redesigned for a lot less to do a lot more?
That's an excellent question, thank you. This is one of the areas where we are going to do things much more efficiently in future. Basically, we're shifting our investment from treatment services towards prevention services. So we think it's important to provide an open access service to people who want to quit, but at the same time we have to acknowledge that the relapse rates are very high, so it's not a very cost-effective way of reducing smoking. What we're now going to commission newly is a schools-based program which is called Assist, which is it's a peer-led program, so you train up influential students within schools who then have conversations with their peers about smoking, and it's been shown to be quite effective in stopping people from starting. I've done some modelling on this. I think it will cost us about 3 times less to stop someone starting smoking than it will to try and get them to quit once they've started. So we're trying to do a bit of both, but I think in spite of the reduced spend on this, we're actually going to have a bigger impact on smoking prevalence with the new strategy.
Thank you.
Thanks, Tim. Good response, good question. Anyone else? Councillor Collins.
Thank you, Chair. Just a question about the sexual health services, which is mandated. I see the spend's going to go up, if I'm reading this correctly, next year. What sort of the challenges there? What sort of services? That's the second one from the bottom.
So sexual health services are a big area of spend. They're mandated. They're clinical services, so we're providing. It includes both family planning and treatment for sexually transmitted infections, and it's clearly provided by an NHS provider. One of the challenges with sexual health services is that there's a national agreement that people should be able to access sexual health services anywhere they want to. So often people don't want to go to an STI clinic close to home for obvious reasons. Yeah. They prefer anonymity. But the principle is that we should pay for Thurrock residents wherever they access these services. So that means that if Thurrock residents access sexual health clinics in London, those clinics can then bill us for that. It's a bit of a mess, I have to say, because the national guidance is not very clear on it, and we have a number of ongoing disputes with trusts who have sent us bills which we don't think they've given us enough information to be able to pay them. So one of the reasons for the increasing spend on that is that we there's a bit of risk involved in that. We can't be absolutely sure how much will be spent outside of the area, and we have some ongoing negotiations, let's say, with other areas on that. So we hope that will be resolved and that we won't have to spend quite as much as we've budgeted for, but we have to be cautious in terms of our budgeting there.
Okay. May I ask another follow-up question, Chair? What's the biggest spend on, family planning or STDs?
Off the top of my head, I would say probably STDs, just because it's a more expensive service, but I'm not 100% sure on that. I could find out for you if you're interested.
Just one more, please. Thank you. Well, if we're going for prevention services for tobacco and control, is there anything we could do regarding educating people for avoiding STDs?
Absolutely, and we do that, and I think that's really important. We have we're in the process of designing a new teenage pregnancy strategy, which will include strengthening sexual reproductive education within schools. I think that will probably, as we redesign our services, that will probably be part of our 0 to 19 package, rather than in the sexual health contract, which is more clinical. But it's absolutely critical, I agree.
Okay, thank you. Thank you, Chair.
No problem. And it's an interesting topic as well, because I assume that maybe does the cost of STD versus family planning, I'm guessing it's not just the kind of treatment, that it's probably the tests as well. So could we presume that actually spending more money in this area means that people are looking after their sexual health and are looking after their futures with regards to family planning?
Yes. In almost all areas, prevention is cheaper than cure. So, yeah, absolutely. The more we encourage good family planning and safe sex, obviously there's cost pressures on those particular services, but it always saves money further down the line in more specialised clinical services.
Great. And one question from me with regards to the redesign and the re-procurement. Obviously, treatment is more expensive than prevention. I think the way to do that, prevention, investing money beforehand is definitely the way to go. I'm just wondering about the impact on the residents that are currently accessing those services. When we have a fundamental redesign, will they be able to still access those services? Will there be a clear crossover so that their kind of treatment isn't too disrupted?
Yes, certainly we would want to smooth any transition. In the main, it's about emphasis. So if I come back to the smoking example, we will continue to have an open access stop smoking service, so anybody who wants to quit will have it, but we'll put less effort into chasing people down and pushing them into that service, and more effort into stopping them from starting in the first place. And I think that principle probably holds across a number of other services.
Councillor Fish.
Seems like there's going to be a lower spend on children and adults' weight management. So how's that service going to move forward with reduced funding?
Yeah, thank you for that. So what we decommissioned is Tier 1 weight management services for both children and adults. So that's the less severe end of things. My own view is that weight management is most effectively tackled not through providing classes and services, but through influencing the wider environment in which people live. And that doesn't need commissioned services. It needs the kind of work that we're doing with planning parts of the council, with environmental parts of the council. So one example is a free initiative which we've promoted in primary schools called the Daily Mile, and it started in Scotland, where primary school children take 15 minutes every day to do walking or running. They try and do a mile. It's massively reduced overweightness in the schools that do it. It's completely free, but it needs the idea, it needs people promoting it, and it needs people evaluating it, and that's the kind of expertise that we can provide without commissioning any services. And my view is that has a much bigger impact at population level than providing classes for people who are mildly overweight, which we can only ever do for very small numbers.
Excellent. Thank you so much. Thank you, Tim, it's very interesting. Again, on this one, can members agree the recommendations and note the report?
Agreed.
Agreed. Yep. On to item number 7, which is the report on the Cancer Deep Dive Health Needs Assessment in Thurrock, which can be found on pages 43 to 118. Can I ask Fumi, can you introduce the report, please?
Thank you, Chair. So I'm here to talk about the Cancer Deep Dive. This was produced as part of the Public Health Core Offer to the CCG. And the document is there. The areas covered are cancer prevention, cancer screening, early identification and referral, diagnosis and treatment, and cancer survival rates. Further to the document being produced, there's been a cancer action plan, which is being produced by Public Health and the CCG to address the issues for each of those areas. So I'm going to briefly go into each of those areas and talk about some of the solutions, which is what I'm sure you're interested in hearing. So starting with cancer prevention, very topical area. We all know that smoking is the biggest cause of ill health and death in our population. And we also know that there's no significant reduction in rates of smoking attributable hospital admissions over the last 5 years, because we know that the systems haven't been as effective as they could be. In terms of the solutions, one of them has already been mentioned by Tim, the ASSIST program. We also are planning to introduce making every contact count in the council to reach smokers and to signpost them into the existing stop smoking services that we have, and also to change current commissioning arrangements with our acute trusts so that they can identify and refer patients appropriately into these stop smoking services as well. So basically doing the job in a different way. And then we come to cancer screening. So we have the three main areas of cancer screening, which is breast cancer, bowel cancer, and cervical cancer. And we know that the main issue here is that there is a low uptake of screening by our population, and the targets that we're trying to reach aren't being reached at the moment. So what we are aware of is that some of our population who are being invited to come for screening are not actually presenting, and we also know that this is happening in a lot of our more deprived areas as well. So we know that as a solution, we need to work together with our communications teams in the council and the CCG to reach the audience that aren't being reached at the moment, to get them to present for screening. For early identification and treatment, the issue is that patients are presenting late for referral, and also the referral processes are taking longer than perhaps they should. Some of the delay is avoidable. So some of the solutions for this is that we have identified practices that could do with some support, and we are using a multi-organisational approach. So the council, the CCG, we also have third sector input from cancer research, and we'll be doing things like offering GP practice visits to those practices that want us to come and offer our support, so that they can do more work to reduce these delayed referral times. In terms of diagnosis and treatment, the issue here is there is a significant variation in unplanned care admission for cancer. And what we'd like to do is look into service redesign to improve access for diagnostics, because we know that there's a lot of avoidable waiting times between different acute trusts for patients to go and get their diagnosis done, because we're working with different organisations and different trusts to get from referral to diagnosis. And some work has already been done, and we've identified that more work will be done by the CCG Cancer Lead with the redesign of certain referral services, such as just a referral form, being easier to use. And then finally, the cancer survival rates. We know that survival rates have increased in the last couple of decades, so it's actually a good news story, really. We're seeing more people surviving cancer. However, we know that the one-year survival rate for breast cancer and bowel cancer in Thurrock are amongst the lowest compared to similar areas, so we know there's more work for us to do for our population. And the solution would be to, by making the improvements that I've discussed in the paper, starting from prevention all the way to treatment, we should be able to see improvement in survival rates. So to summarise, the deep dive or health needs assessment was completed, and the issues were highlighted and have been addressed. We know what we need to do, and we know that it will take work from multi-organisations to work together, basically, to be able to see these improvements and to be able to action them. And the Cancer Action Plan that we're working on is a working document that will hopefully get us there. So what I'm asking for today is that the committee note the report and give us the support in terms of our actions.
Great, thank you for this report. It's a very, very detailed and a very important report, so thank you. Do you members have any questions? Councillor Watkins.
Thank you, Chair. I've got a few questions. I'll try and keep them short. I ended up having 2 pages for the questions, but I won't go through that many. It kind of goes on to what Councillor Snell mentioned in a couple of moments ago with one of his questions, which was saying actually I was going to mention anyway, so I won't refer to the tobacco kind of prevention, because I know it's already been worked on.
Sure.
In regards to the screening services,
yes.
Is there going to be much work in regards to prevention for at a children's level? So teaching kids the importance of when they're getting older, of looking after themselves, checking themselves, and obviously going through those preventions, which might help the younger generations who are not obviously turning to screenings.
Absolutely. So the example which was used, which I can expand on, is the assist to prevent young people from taking up smoking in the first place. Then you don't have to, treat the cancer. So yes, there are a variety of ways that we would look into, promoting health from early ages. So targeting obesity, targeting smoking, making young children more active. All of these things prevent the variety of different things that cause cancer in the first place. Yeah, so definitely prevention.
Is it okay, Chair, just to have a follow-up? Yes. So, also in regards to, if I take the example of when women go and have their checks done every couple of years, obviously, I don't know, obviously those numbers would have been taken into account, those who attend those services and those who don't attend those services. In particular as well, teaching, as I say, kids from that point of view, of the importance of going to those checkups every couple of years, for both men and for women as well. And as a counter with that as well, something I've seen used in some areas, which seems to work quite well, in expanding with a wider kind of audience. Is there any ideas of like action days almost? So I give one example, if that's okay. At some football clubs, they have a testicular cancer awareness day when they bring trucks to the games, for example, and they encourage people to go earlier before and have checkups. Those kind of events to try and also branch out to wider audiences. Is that kind of things being suggested or kind of thought about?
I think we're aware of a number of different types of those interventions. Yeah, so I think I'm familiar with them for testicular cancer, possibly prostate. We have health checks. In the workplace. So I think we do have a number of different interventions that go on to prevent. Oh yeah, Mandy, were you going to?
Oh yeah. Is it related to Councillor Watkins?
It is.
Yep. Okay, come in.
So just to, I can see you're very interested in this. Just to add that our weekend GP hubs that we have, we've opened special access, particularly for cervical screening, but testicular screening too. We could certainly, if people were worried, so that particularly if women don't want to go to their GP because they're male, we have a nurse service there at the weekend. So we did identify that as a way of bringing the numbers up.
Thank you. You can come back in, Councillor
It's
Watkins.
okay for one more
Of course,
question,
yeah.
yes. It's kind of actually related to something slightly different. On page 99 of the report, and obviously there was kind of a common theme I noticed as well in regards to some of the practices. Obviously, some of those falling below the national standards and averages, which obviously was anticipated, so they're obviously being investigated. You mentioned that there's going to be support and guidance given to those areas where they need it. Is there going to be performance markers almost put in place as well? So there's almost targets in which they have to reach, or so we can keep an eye on those practices which we're kind of identified as a problem, and make sure that we can see a substantial change over years?
Yes. Yeah, you can.
Want me to answer that one? So the GP contract is not managed by the Clinical Commissioning Group. It is managed by NHS England. However, we, as a CCG, have identified the need for quite a range of development issues across the practices, and this is just one example. So we have put in place a team that is dedicated, and as Tim has described, to looking at a whole range of indicators, and this is just one of them, to try and support practices in making sure that they are performing to the best they possibly can. Now, people are probably aware of the CQC, who go in and assess all health providers for quality, safety, patient feedback. And we get feedback from the CQC as well. So there's a number of ways through the contract management that comes through NHS England, through the CCG, through our development team, and obviously very, very close working with our cancer lead through the cancer action plan that Tim's talked about, supported by Public Health.
Thank you, Mandy. Do you want to come back in, Councillor? I know this is it's very important to many people, and every council will have an opportunity to speak, but bearing in mind your 2 pages of questions, if you want to ask another one, I will...
And that's okay, I'll let someone else step in for the time being. I might come back in a bit.
Problem.
Thank you.
Councillor Collins.
Thank you, Chair. The question stems from page 49 about the disrupted care pathway. What sort of... where it says here, pathway operates as a series of linked individual processes, staff only taking responsibility for their part of the pathway or process. As soon as one part of the pathway failed, the entire pathway failed, and a delay occurred. Patients often appear to be bounced around different providers and different parts of the NHS system, with no one individual taking responsibility for their journey through the pathway. Are you looking at ways of reorganising the care pathway?
Shall I take that one?
Yes, please.
Thank you.
Yes, so the pathways are a number of handoffs because cancer is treated in what are called compliant pathways, and those pathways tend to move across a number of sites. And some of our pathways go into London. I know Ruth is still sitting behind me here. Some will go up into Addenbrooke's. So it's where there's obviously the specialist treatment, but diagnostics can be one of the bottlenecks. Mm-hmm. So where particular scans, and we've mentioned the PET scanner today, scans are required, or particular investigations. One of the things that as a group of CCGs, and we're going to talk about the Essex Success Regime in a minute, one of the things that we as leaders in each of the CCGs are very aware of is that we have to see the whole system, because there's no point me just looking at what's happening at Basildon Hospital. I need to know what's happening at Southend Hospital, I need to know Mid-Essex, and actually wider, often into Queen's and often up to Addenbrooke's. So a group has been established to actually look at where some of those major bottlenecks are. Now, it won't surprise you to know that one of the big challenges is actually workforce. And Ruth mentioned the urology pathway that's being recommissioned. That is a particular specialty, and back to the testicular cancer. That is a particular pathway where the workforce is extremely challenged. Mm-hmm. But we as you know, NHS commissioners, and certainly the providers, are aware that we have to smooth out those interfaces for the patients, because the patients should feel a seamless pathway, and it certainly is incredibly high on the high priority list at the moment.
Chair, I was going to say, it's absolutely where NHS England in its commissioning role and CCGs collaboratively need to work and do work closely together, particularly, and that may be through what I'm going to be called Cancer Alliances. So you may have heard through the Cancer Task Force is very committed to improving intervention, but also in ensuring that we get early intervention through early diagnosis. And so we are committed to doing that together, and we jointly funded across the Essex system something we would stop doing.
Thank you, Ruth and Mandy. Councillor, would you like to come back in on that? Or?
If you wouldn't mind.
Of course.
I understand your points about bottlenecks, but don't you have somebody, an organiser, or something, a patient champion, who just chases the progress of the treatment and chases up people who are a bit slow in delivering the particular care? Are we looking at doing something like that, please?
Yes, so cancer patients are managed by what are called multidisciplinary teams, and within those teams there are consultants, there are nurses, there are people who will track the progress, but it is very much around capacity.
So if there is a limited capacity, then a queue forms effectively.
Okay.
And that, as Ruth has just alluded to, is actually the role of this task force that is actually going to look at how these can be alleviated.
Okay, thank you. Can I just ask one more?
Of course.
It says down here that, on the same page, over the last 20 years, patients diagnosed within Thurrock have generally survived for shorter periods of time than England, than many of our compared CCGs. What would you think is the cause of that?
Well, there are a variety of reasons. I think deprivation in Thurrock is one area where we know that survival rates are lower in the more deprived areas. And I think with that sentence, what we're saying is actually it has increased. The 1 year survival rate has increased. So it's actually a good news story. It is lower than England, but it's not significantly, so we don't see it as a real difference.
I'll probably just add one more point there, which is survival rates are strongly affected by how quickly cancer is picked up and treated. We have an issue with late diagnosis, and that there's two factors there. One is how early people present to their GPs usually. So are people aware enough of their own health and coming forward well enough? The other is how quickly the system diagnoses them and gets them into treatment. So we've talked about some of the issues there. There's two sides to it. There's a health service side. There's also a public education side to this, which is where some of the campaigns that we've discussed come in actually. And we need to be working at both ends of that really to make sure we pick up and treat cancer earlier. That's what will affect survival rates.
Thank you, Chair.
Thank you, Chair. Just looking at everything where we seem to be falling badly behind on the screening and everything else. We're below targets on virtually everything, and yet once people are diagnosed, the treatment is very good, and that part of it's performing very well. Is this not the same things we've been seeing time and again in Thurrock, where looking at these figures here, we've got a third of doctors that don't appear to be referring people when they should be. Can I assume that's in the usual areas where we have the same problems time and again with doctors really not doing the job as well as they could be doing? And parts of some of the GPs are doing quite well, but not very many. Is it yet again a sign that the GPs really do need a bit of a kick up the backside and get their acting gear a little bit?
I think that goes back, Councillor Snell, to the point I made about us supporting primary care jointly with our public health colleagues, and we do also have a lead in the CCG as well, a doctor who goes round to practices and supports. So I think that is the point that's been made, that yes, we can see that more needs to be done, and there is a support mechanism in place for that.
Of course, yeah.
It's only just that we've been seeing this for a while now, and if it's getting better, it's not getting much better. So can we expect to see a few more improvements with whatever has been put in place now?
I can mention just that it's not only about the GPs and the GP practices. So, for example, with bowel cancer screening, we know that GP practices have very little involvement in the actual screening program themselves. So the issues are bigger than just looking at the GPs and the GP practices. I understand what you're saying, that it's been going on for some time, and there are numerous things that we've discussed this evening about how we're addressing cancer to try and get more improvements.
Yeah, I understand that, and I do get that. But in this report, we've got 9 practices, which is nearly 28% under referring. There's obviously a reason for that, and I would imagine that's been historical. Certainly, in other meetings, we've had other issues where, again, the GPs have underperformed quite badly in some places. Yeah. So this seems to be a historic problem with certain GPs.
The report does mention under-doctoring, so we know that we have an issue where we don't have enough doctors, and some of these areas are the ones that are in the greatest need, and that's been a long-term issue. I don't know whether to bring in the... No, okay, yeah, that's it.
No, again, I understand what you're saying about lack of GPs, and that's an issue, but this isn't referring to a lack of GPs. This is saying that 28% of the existing GPs are not referring, so there's obviously a problem there, that's all.
I think what would be helpful, I think, is to find out, bearing in mind one of the recommendations is for us as a committee to support the work that you're doing and the work of CCG colleagues and partners. What can we do practically as this committee and as members to actually make sure that some of these changes are implemented, because it's suitably vague, and whilst we wholeheartedly do support what you're doing, what can we do really practically to ensure that we are moving things forward and we are seeing a change?
I would say probably the most important thing is to keep asking the difficult questions that you've been asking and not to let them go away. I think these are systemic issues. They involve some of the most complex clinical services that are provided in the NHS, and they involve working across a number of organisational boundaries. So I would say the most important thing is to keep on our case to make sure that we are moving these things forward.
Okay, it might be the case that we have to put it back on the agenda for in a couple of meetings' time, but we can discuss that as a committee in the last agenda item. Just going to lastly bring in Councillor Howden, who's put his hand up.
Thank you, Chair. Just to provide Councillor Snell some assurance, you're right, it isn't just about having a lack of current GPs and needing to attract new GPs to the borough. It's about holding existing GPs to account, and where we have got poor services, being entirely comfortable with the idea of naming and shaming those poor services. The Director of Public Health is already doing a great deal of work on making sure we've got metrics that actually make sense for the population of Thurrock, to ensure that when we are using statistics and data to hold providers to account, it's actually based on the health profile of the borough, so holding them to account on the basis that actually makes sense for what our patients need. And it's also why I'll be chairing the Health and Wellbeing Board myself, so I can work with colleagues in the CCG who have been doing work modelling a new primary care system in Tilbury to ensure that we can head off these problems earlier. We can see where the data's going. We can head off problems with poor providers to ideally make sure the next time we're not talking about how we are going to solve a crisis like we've seen in Tilbury, how we're going to prevent a crisis like we've seen in Tilbury.
Thank you, Councillor. I think there's a recurring theme, which I'm sure has been in previous meetings, which is prevention. On that note, will members agree, if there are no other further questions or comments, will members agree the recommendations in the report?
Agreed.
Agreed. Brilliant. Next item number 8, is the report on domiciliary care. This is on pages 119 to 126. Can I ask Roger, and I believe Catherine, you'll be making some interventions as well to introduce the report.
Thank you, Chair. I'm going to kick it off and give a bit of the context and some of the difficulties that we're facing, and then Catherine is going to have the slightly easier task, perhaps, about talking about some of the solutions. I think committee's been briefed fairly regularly. Certainly members that were on the previous HOSC will be aware of some of the difficulties that we've been facing in domiciliary care over the last 12 months in particular. This is not anything that's unique to Thurrock. I think domiciliary care nationally is facing some very, very stiff challenges, but there's some particular challenges that we're facing in Thurrock. We retendered the service 18 months ago, and we had on our framework agreement 3 main providers and a further 2 what we call spot providers. Domiciliary care is by and large provided in the private voluntary independent sector. Thurrock at the time only had a very small in-house team, mostly around sort of the reablement service. The challenges that the service is facing are very much around workforce. There are increasing pressures financially they're facing. The national living wage obviously went up from £6.70 to £7.20 on the 1st of April this year. There are other pressures around around auto-enrolment, in terms of increases in terms of pension requirements. CQC is also quite rightly and quite understandably has a higher expectation of the quality of service that should be offered. And also, it is becoming very difficult to attract staff into the sector. There's a very high turnover of staff. You can understand it in a way, would most probably prefer, if they want to be in the care sector, find it a better environment working in a residential care home or in supported living, rather than working in a situation where they're visiting someone's home. They often not get paid travel time, and the salaries tend to be at the national minimum wage, or now the national living wage. A particular challenge we have in Thurrock is obviously being on the edge of London. The rates that we pay are lower than tend to be in the rest of Essex, and what you can get working for an agency in London. So again, there's quite a high turnover of staff. We've run into some some difficulties with our existing providers. One provider, we were so concerned about the quality of service on offer that we had to bring the service back in-house. That has caused us. That happened at a very short notice. That we did it jointly with CQC, the care regulator, and that happened just before Christmas last year. And there's still some settling in issues that we're having to sort out. Another provider felt that even though they put in a tender for the service, 1 year into the contract, the service, they took a business view that it was no longer financially viable, and so they gave us 6 months' notice and handed the work back to us. Nationally, there is the UK Home Care Association who's doing a lot of lobbying about the home care market. There was a national piece of work undertaken by Paul Burstow, who used to be the Minister of Care, and the sort of accepted rate now is that what would be called a sort of a viable rate for home care is around about £15, £16 an hour, and that will go up year on year as the national living wage increases up to around £9, I think, is the government's target. So we've had to bring 2 services back in-house, and we have now got an in-house service because we were so concerned about some of the stability of the market locally, and also just to give us some capacity to respond to any safeguarding concerns, any crises in the market locally, but also we felt that we had to bring some services in-house. We've also had to recognise the financial pressures that some of the providers were on, and so some of the money that was due that we raised this year through the adult social care precept, so the council tax, there was an extra 1.99% put onto the council tax this year, along with the 2% that members agreed. So some of that has gone to invest in domiciliary care because the market was so fragile. The current contract has got a year left to run. We feel it will be a difficult year this year. We're working very closely with our providers, but we've come to the view, as a number of authorities have, that the actual fundamentals around home care need to be quite radically changed. And I'm now going to hand over to Catherine, who's going to talk about what the new service we hope will look like when we go out to tender later this year.
Thank you. I think, as Roger says, we are really clear, and it is backed up by kind of national and international evidence, that the way that domiciliary support is provided at the moment is really untenable, and for the reasons that Roger has described, that often it's a kind of a big service, not locality based, and it's very difficult to retain staff and to recruit staff. So we want to look at a new way of providing domiciliary support in Thurrock, and we've begun that process with really talking to our market. So we've had 2 what we've called soft market testing events, where we've invited potential providers to talk to us about how domiciliary care is provided. We've also done some work with our operational colleagues around the difficulties they face in supporting people who require domiciliary support, and putting that together with the reports that have been written and looking at how colleagues have tackled this issue in other local authorities. it becomes very clear that in order to deliver a high quality service, we really need to have locality, community-based services. We need to have agencies who would provide support, who would focus on an area and really get to know the people that they're working with, and that gives us lots of safeguards around quality and the levels of support that are delivered. And so in order to really look at how we're going to do that, we have decided to run a pilot scheme based in South Ockenden, looking at around about 75 to 80 people who currently receive domiciliary support, and really looking at how we can mobilise the community to offer additional support. So traditionally, I think you will be aware that domiciliary support is often just viewed as personal care, medication prompts, providing meals for people. But often we find people who receive those supports really find themselves very isolated and unbefriended, and often people who don't have families as well. And so it's really thinking about how the community can offer some additional supports, and we can look at new ways of working with people. And also we have very large contracts that often can be unsustainable. And so thinking about how that is funded is crucial. I mean, we currently have, as it states in the report, we spend in excess of £8 million in supporting people to live at home through domiciliary support and other supports such as equipment and Meals on Wheels. And we need to think about how we can refocus that support, because there is unprecedented challenge around the savings that we need to make within the council and within adult social care. And so we have to think about perhaps people having their own budgets and being able to purchase their own supports, and also, as I say, how the community might be involved within that, and particularly the voluntary sector. And so with this, the pilot, we are looking to start towards the end of the summer, and we're hoping to use a lot of the data and information that we'll have from that to develop a new model of support. And we'll also be working with colleagues across the country to learn from them what's been successful and how perhaps they would have done things differently in their redevelopment of domiciliary support. It's something that's happening all over the country, and it's a really positive time in many respects, although it's a huge challenge at the moment for us that we can actually redevelop how we redesign our domiciliary support. So I think that, unless you want to add.
The plan is that we will bring back in the September meeting of Scrutiny Committee, most probably will go to the Health and Wellbeing Board as well, what that sort of service model will look like. As Catherine says, much more sort of patch-based, looking at sort of working with local communities, and I think the evidence is that if you could actually, what happens at the moment is that people will have a call in Tilbury, then they'll have a call in Ockenden, and they'll have to come back to a call in Corringham, and they don't get paid the travel time, and so they pinch 10 minutes off here and 10 minutes off there, and they're rushing from service to service, and it is a very unsatisfactory service at the moment. So we're looking to develop a more patch-based service, working with the local area coordinators that we feel actually will be more efficient but delivering a far better service. So the plan is to bring back that sort of service model for you to comment in the autumn before we go out to tender for it.
Great. Thank you, Catherine and Roger. And that was going to be my first question, as it says here, consultation, including the Overview and Scrutiny Committee, if applicable. But if the plan is for September, that's my question answered. Does anyone else have any? Councillor Watkins, you have your hand up first.
Just in regards to the South Ockenden pilot, how are you going to measure the success of it? What kind of performance markers are you putting against it? Is it going to be weighted towards more those who obviously work within that, or is it going to be those who are receiving the care?
Both. I mean, there will obviously, be some standard metrics about, no missed calls, complaints, but also we want to get service user feedback. Did they feel that? Because I think the problem at the moment is that people come in, they do. It's a sort of task and time structure to it. People don't necessarily look around the house and think about, well, there's not much food in the fridge, or there is, there's some trips and there's some carpets that someone could trip over. over? Why is the heating not on in the winter? So we want actually people to start to think about what the brand that we're going to be using is living well at home. So it's just not a sort of 9 to 10 call. It's about looking at sort of wider health. So some of these things will be quite long term, but the most fundamental thing will be from the users themselves, their feedback. So that will be the main indicator we will use.
Thank you, Councillor Fish.
Thanks, Chair. I think the plan that Catherine's outlined is greatly to be welcomed. I think there are, from my own experience, there are community assets out there that we can make more of. But I'm just interested to know why you chose South Ockenden to do the pilot.
I think we chose South Ockenden because of the community hub and also the really positive work that's going on there through the voluntary sector. And it was a very kind of discrete area. We kind of analysed a number of areas across the borough, and we found that there were there was a good amount of people in quite a discrete place that we could actually work with and focus on and look at the community assets. And so we decided to go there. It could have been a couple of other places as well, but we just made the decision to go with South Ockenden.
Councillor Snell.
Thank you, Chair. I'm not wanting to sound quite like Councillor Gerard Rice. I remember back in the 1970s when I moved out as a kid with my family to South Ockenden, of all places. And back then there was a real big community spirit, and there were always ladies who were prepared that when somebody was ill they would pop in and they'd make sure they got fed or they'd do some cleaning for them, and it was never a problem. Now, I don't think that spirit ever really went away. It's just that the community's changed so much that kind of got lost a little bit. And this is the sort of thing that I'm really sort of quite passionate about, to try and bring that back. And I think with everything that Thurrock Council is doing of late, I think it's a recognition that actually what we lost over time was the spirit of community. And we're bringing it back in the method you suggested. I can't see why it wouldn't work. I think those people are still there. I think there's always going to be people that are keen to get involved and get stuck in and help and do just these things. If we're talking about a professional to go around to make sure they do the professional bits, and then maybe some other people that do follow-up visits because they're in the community and why not, I think that's terrific, and I'm really looking forward to seeing how that goes.
Thank you. Does any other members? Oh yes, Ian.
Just a quick question again about the South Ockenden pilot. I just wondered if you've got any plans around involving individual service users in the actual design of the format and the template of the plan itself and the questions that you'll be asking when you assess them for the support that they need. Thanks.
The short answer is yes. We have, yes. And part of the kind of engagement process as we move forward is initially over the summer we're going to be meeting with service users, explaining what we're hoping to achieve in South Ockenden, and we'll be working with people who live there and receive services, but also more widely as well through our engagement group. We really want to understand how people feel when they receive domiciliary support and what would make it a better experience for them.
Great. If that's all the comments from members, I think it's there's some positives and some negatives. Obviously, it's a very critical time and it's a real breaking point in the service. But if we can harness the potential of the redesign and the community spirit, as Councillor Snell talks about, then it could be a fantastic service. So if we look forward to bringing that back in September and discussing that more. Are members in agreement with the recommendations from the report? Agreed. So Jenny is kindly setting up Wendy's presentation now. So we've got another PowerPoint. While she's doing that, I'm going to introduce Wendy while the PowerPoint is being set up. It's Wendy Smith, Interim Communications Lead, Mid and South Essex Success Regime, who's here to introduce the report and presentation. Wendy, I'll hand over to you.
Thank you very much, Chair. Can I just check with Mandy whether you wanted to say something first before I dive in, or shall I just do something first?
You start. I'll dive in
Well, thank you very much for the opportunity, everyone, and hello. This is an early stage in some ways not, because it's a part of an ongoing programme. But the reason why I'm here tonight and we're bringing this item is because we are proposing potentially, when I say we, I mean health and care. It's a big we. In Essex, in Mid and South Essex, some transformation, and what will come along later this year will be some proposals on options, and inevitably we will need to do some serious public consultation, and hence we want to pave the way. So we're starting with you this evening, and we hope that this will be the start of an ongoing relationship, and that you'll be able to hopefully advise us on the key issues of the public interest, of course, and what you think of the methods and any help we can get by working together in partnership will be good as well. So we will be coming back to you later in the year with a more specific consultation. So at this stage, we're in what we call a discussion stage, and we're about to involve more service users in giving their input at a pre-consultation business case stage. I don't want to go in great detail, and the presentation is a longer one than is really proposed for tonight. I brought it along because this was a presentation that had previously been prepared for the Essex Health Overview and Scrutiny Committee, and it's important that everybody has access to the same level of information. So what I really wanted to do was to sort of leave that one with you through your offices. Maybe, I don't know whether this has been copied round to people, but perhaps that's something that can be done. And for tonight, to just sort of do the headlines and clearly be here to answer any questions. So I just wanted to say a few words on the vision that this is about. So that's the good news, if you like, and then a few words on the challenge, which is the difficult bit, and then just simply outline what it is that the overall plan is seeking to do. So you've got the picture, and then say something about our plans for further involvement with service users, general public, and eventually consultations. That's what I'm going to try and cover in a few minutes. In terms of the vision, I'm sure that when you become acquainted with this vision, and it will become more articulated in detail in something called the Sustainability and Transformation Plan, which is a draft is due at the end of this month, and we will make sure that you will see that, and our colleagues in the council here are involved, and the Health and Wellbeing Board, of course. So the vision has a lot of alignment with a lot of the things that Thurrock does and has believed in for some time. And to put it in a nutshell, we're looking at a transformation where health and care can be more and more local. So we're looking at ways of finding what is the sort of locality size that's going to be the right size for truly knowing what people need and being able to deliver those needs on a person-by-person basis. And at the moment, GP services are at the heart of NHS services, and that will probably continue. They're kind of the centre of it and the place where you begin. And there's already been lots of work in Thurrock along these lines in building up the idea of bringing together primary care, the GP services, community care, social care, mental health, and joining those services together so that they can work from the base of the GP group, if you like. And I know you're ahead on some of that development here in Thurrock. The idea of that is to, as I say, meet people's needs on a more person-to-person basis and to put much more emphasis on prevention. Prevention in a public health sense, and also in terms of managing chronic diseases and situations. And that then brings you on to the sort of second big element of the story, which is about keeping people well for as long as possible, to be as independent as possible, and crucially to avoid the crisis or to avoid hospital admission and the use of hospitals. Because I'm sure you would agree, it's kind of well known that at the moment there is a heavy reliance on hospital services, which is a very expensive way of delivering care. So there's a lot of work, and in fact Thurrock is leading on a key aspect of that work, and I think Mandy might mention something about that in terms of frailty, older people and people with complex needs. So then the third thing that you then lead on to is, okay, so let's look at the acute end of it, the hospital end. And we've got 3 hospitals within the area being covered by the success regime. That's Basildon, Southend and Chelmsford, Broomfield. And the idea here is that we can see the potential for 3 hospitals to work together as a group, and in fact they've agreed that formally now, to look at where things can be done once, not 3 times over. So you would immediately grasp the idea about back office functions. There are going to be services and things that are not necessarily frontline services, sort of support services, clinical support and so on, that you could do as one. But equally, there are many opportunities for the clinical side of things, the services to work together. And at the moment, we don't know precisely what those opportunities could be. We have some good ideas because the clinicians are currently working on that, using national guidelines and evidence and service user input at the moment. So the clinicians currently are considering how emergency care might work, because that's a really crucial part of the service, and then from that the interdependencies and how other services in the hospital might work. And one of the big themes is the idea that there would be 24-hour emergency care at the 3 hospitals. That would continue, but for some of the more specialist end of emergency services to follow the national guidelines and designate a centre for that sort of thing. And in fact, that does already happen in some ways at the moment. Here in Basildon, there's the cardiac centre you'll all be familiar with. So someone who lives in Malden, in Mid-Essex, for example, if they have a serious heart attack, whatever, they would be brought to Basildon by ambulance. They wouldn't be going to Broomfield, and that happens today. Another example of that would be serious trauma, multiple injuries from a road accident, for example. If you have a really serious road accident on the A12, say even in the South End area, you potentially might be going to Addenbrooke's or another hospital, not South End. So that happens now, this idea of the specialist end being better delivered in a place where it's a hub of expertise. So we think we can do more with that. There's greater potential for that to then allow the hospitals to be more efficient and more caring for each of the individual patients they see. So that's the vision. I just want to say something about the challenge, and this is where there is a slide for this. If I just flick on to missed it. There it is. It's the money side of things. So the vision delivers better care for people. There's a lot about it that's better for people. But it also has the potential to make it possible to deliver more in health and care with the resources we have. And we know that those resources financially are not going to increase. And yet, at the moment, the way that things are organised mean that We've got a deficit now. We've had a deficit historically, so we sort of carry that along with us every year. But we also clock up another deficit on top of that every year. So at the moment, we are getting further and further and further into the red. And if we let this go on without doing anything to change it, then the likelihood, it's not actually explicit on this particular slide, but the likelihood is that we could be reaching over £218 million in deficit by 2018-19. Now, if we got to that stage, then we couldn't carry on delivering healthcare year on year, meeting the increasing demands that we have. That just would be impossible. And we certainly wouldn't be able to deliver the vision that I was trying to outline earlier. So this is why we have a success regime. This is why the NHS England has highlighted this area along with Devon and Cumbria as a place where there should be some extra help. There's a combination of support. It comes by way of funding, and it also comes by way of management expertise, and that's all very positive. And there's also a challenge. We've got some tough deadlines to meet, and we do need to outline a very detailed and robust plan that will get us to a break-even balance by 2018, which is what we've currently got as the plan. So what are we going to do? Well, in the pack, there are 6 areas that have been highlighted as the ones to be the main areas for change. And it really follows a lot of the themes that I've just said. Addressing the clinical and financial sustainability of the local hospitals through working together, and then accelerating some plans for changes in urgent and emergency care, meeting the national recommendations that we don't currently meet, and joining the community-based services and building those around localities. They're the big ones, and then we've got some enablers around reducing the workload in terms of bureaucracy, because we've got over 300 contracts that we try to work, and we can reduce those down to potentially 50. There's also a workforce element to this, developing a flexible and newly skilled workforce, and information. It comes up every time, and it comes up every time we talk to the public as well. The idea of how, wouldn't it be easier and better if everybody had access to the same information, which we don't. So I'm going to stop there and hand back to the chair to continue with the item in whichever way you think's appropriate.
Thank you, Wendy. I appreciate you presenting it in that way, because it obviously is a very complex and detailed area. Mandy, do you want to come in before I bring in members for questions?
Yes, thank you, Chair. I think it's useful to actually bring this now down to Thurrock. And can I just take people to slide 13, because I think this cuts to the very core of what we are about in Thurrock. And certainly, Councillor Howden, thank you for mentioning the work in Tilbury. It is incredibly complicated, but it is acknowledged, and thank you, Wendy, for acknowledging that actually Thurrock CCG is at the cutting edge of the community out-of-hospital piece here, and as such we will be leading the frailty pathway, which I would say is probably the bulk of the out-of-hospital piece. But what's really important here is to understand the integration agenda. So this is something that Roger and I and our teams work on through the Better Care Fund to deliver a much more integrated model of delivery, partly out of economics, but certainly most importantly out of patient experience and quality of care. Excuse me for highlighting this again, but we were the only CCG in Essex that actually achieved the reduction in unplanned care that was one of the targets in the BCF last year, and as such have been able to reinvest £800,000 into our community services to further keep people out of hospital. So in the wider context, We have already consulted on our out-of-hospital strategy, and that was an exceptional piece of work that was led for us by Healthwatch. So we've already gone out to our public around reconfiguration of beds, including how we work with Catherine and her team around intermediate care services. The models that we are proposing in the 4 localities, so Councillor Holden has mentioned Tilbury, same model in the Purfleet as will be in up at Thurrock Community Hospital, and in the new build that is coming forward in Corringham by Nelft. So we are looking at integrated services in the widest sense, so through the voluntary sector, through council services, and trying to address this issue of lack of GP capacity. So the thinking here is that we take a multidisciplinary approach. We have GPs doing what GPs need to do, but things that they don't need to do will be picked up by other health professionals or indeed social care partners. So, for example, a number of GPs' consultations will be around housing.